So thanks for the opportunity to come and discuss today about the utilization of radiation in the management of kidney cancer. So during this talk, we're going to briefly go over what radiation is and the different approaches of it, how radiation can be used in the treatment of patients who have localized or non-metastatic renal cancer, how radiation may compare to other interventional radiology ablative treatment approaches, and then conclude with how radiation may assist in patients that have metastatic kidney cancer. So what is radiation therapy? So radiation is the delivery of high energy X-rays from outside of the body, multiple different angles towards the target of interest. And in this particular case, you can see that those radiation beams are targeting a tumor that is within the actual kidney. And so what we believe happens is that radiation goes in there, kills the cancer cells, and then over time, the healthy tissue that is around it begins to heal itself. So radiation in general has been absent from RCC treatment for several decades, and there are several reasons for that. But one of the main ones is that radiation has had a reputation of not being as effective in kidney cancer. And so the term that we would use is that kidney cancer is radio resistant. And this is because the older studies that evaluated patients treated with radiation demonstrated no improvements in their outcomes. And so for this reason, surgery, interventional radiology, ablative procedures, and systemic therapies have kind of been the main treatment approaches for patients with kidney cancer. And this was about until the early 2000s, where there started to be a lot of advancements in the way that radiation is delivered. So if we use this here as an example to kind of describe how radiation has evolved, you can see in the top left panel, there's kind of a mold of a guy, and then you can see right next to that, there's a block. And so if you use the way radiation used to be practiced many, many decades ago, and let's say we were just trying to target something that's in a patient's pelvis, it's just like an X-ray coming down and you really can't see anything. And so if the goal is to try to make the radiation beam as close to the way that the figure looks, you can look at that block next to it and you can say it's not very precise, right? It's just a block. It's not following the contours of that model. So if we fast forward to the next level of radiation, now you get into three-dimensional radiation, where you can look at that figurine, and now you can see that the radiation can actually carve around that target a little bit more, and it looks a little bit more like a person and not just a block. And then if you look at the example down in the pelvis, you can see the radiation's going through the pelvis, but if the goal was just to treat, let's say, the lymph nodes that are sitting in the pelvis, it's really not only targeting that area, it's hitting the bowel that's in that region. So then we fast forward a little bit more, and we get to three-dimensional radiation, plus a way to sculpt the radiation beams as they're being delivered to the patient. And now you can see that that block has become this beautiful artwork where it looks very close to the way that the original was. Now that's a little bit of an exaggeration, but that's what we kind of think when we're delivering this more advanced radiation approach. And you can see that bottom panel on the right is that the overall goal here was to treat the pelvic lymph nodes. So not only can you see the anatomy, but you can also see that the radiation dose sculpts very nicely in that pelvic lymph node area. So this has continued to evolve even further, where we can create videos of patients as they're going through treatment. And if we take, for example, kidney cancer, when you breathe, your kidneys are going up and down. And so if the goal is to just treat the tumor in the kidney, we can create a video of how the patient breathes, and we're watching this in real time, and we have advanced technologies that if the tumor target goes outside of this margin of error that we create, then the radiation beam is not even on, okay? And that's called adaptive radiation, and that's also technologies that Moffitt has here as well. So when we think about the classic radiation of what I was indicating has shown not to be as effective for patients with kidney cancer, this was usually a low dose of radiation for each treatment, which we also call a fraction. This also included those larger treatment regions, which weren't very specific, and usually that radiation approach is over more than 5 weeks. When we talk about the more advanced and focused radiation, a term that we call stereotactic ablative body radiation, or SABR, then this is high dose radiation per each individual treatment. The target areas are much smaller, and usually this can be delivered in a single treatment or even up to 5 times. So I hope to convince you, during this discussion that the response of kidney cancer is actually much greater when you use this higher dose radiation approach compared to the older low dose approach. So the first thing that we're going to discuss is the management of patients who have non-metastatic RCC, so stage 1 kidney cancer. And so currently there's about 15 prospective trials out in the literature, roughly about 300 patients. And what it shows is that there's a range of about 75 to 100% probability that the area that is treated with that high dose of radiation, which I'll call SABR, can lead to really good tumor control. And so currently the highest quality data to date is from this clinical trial called Fast Track 2. And in this trial, what they did was they took patients who had primary RCC. These patients were not fit to undergo surgery, or they declined surgery. There were 8 centers that put patients into trials, which was about 70, and then the SABR was delivered as a 1-time treatment or a 3-time treatment. So at about 3.5 years of follow-up, not one patient has had a recurrence in their kidney that was treated. 97% of those patients have also not had their cancer spread at 3 years of follow-up. Only one patient out of those 70 needed to go on dialysis because their kidney wasn't working as well anymore. And overall, the study showed there was really no severe toxicity in those patients that were treated. So you might say, well, doesn't SABR impact kidney function? Well, the answer to this is that yes. So this is an image that's demonstrating the function of a kidney using an imaging approach. And the green represents the area where the kidney tumor is at, and that's where we'll say 100% of the radiation dose went to that area. And if you follow that green circle as you go from the 12 months to 24 months, you can see that that brighter signal actually starts to go away in that region. And that's because the radiation has killed the cells in that area, so therefore the kidney function has gone down. This would kind of be a very similar association that you would think if you underwent a partial nephrectomy. You remove part of your kidney, so therefore it's not working anymore. So if you think of radiation as a virtual surgery, it has led to the same effect. So the study demonstrates that patients can expect about a 20 to 30% decrease in their kidney function over the course of 2 years, but then it plateaus. And so this is why it's very important that if you are to undergo SABR to the kidney, that you need to have a good baseline evaluation of your kidney function. So then you might ask, well, what if I only have one kidney, but then I develop a cancer in that only kidney? And so this is a pooled analysis of 81 patients who were treated with SABR to that kidney. And what they found is that the ability to control that tumor was almost perfect, and not one patient had to undergo dialysis. So this demonstrates the feasibility as well as the safety to give patients an alternative treatment option who meet well-selected criteria to utilize this to help treat their kidney cancer. So how does SABR compare to some of the other non-ablative interventions that are out there? And so these could include radiofrequency, microwave, or cryoablation. Now, all of these are considered to be non-invasive or minimally invasive. And so there was a recent study that came out of about 9,000 patients where they were treated with one of these ablative approaches. And what the data shows across all these different treatment methods is that SABR had a numerically higher local control rate compared to all those approaches, especially when the tumor was greater than 4 centimeters in size. But what's really important about this is that all of these treatment options for patients were associated with low side effects overall. So this requires good multidisciplinary discussion with your physicians, yourselves, your family members, etc., to try to navigate the process to figure out what is the best option for you if the surgical treatment approach is not what you're going to go through. So, in general, SABR for a primary kidney cancer has excellent tumor control, low toxicity. Overall, the risk of having to go on dialysis is less than 5%. Compared to other ablative approaches, if the tumor is greater than 4 centimeters, there is encouraging data out there that said that SABR would do a better job at controlling that tumor. And SABR is actually recommended in many guidelines across the world as a treatment option for patients who may not be the best surgical candidates. This other image here on your right compares SABR versus surgery versus some of those ablative approaches. And what you can see is that SABR does not require anesthesia. SABR will not be limited where the tumor is located in the kidney. So if it's in the center area near the blood vessels or the ureter, we could still do SABR in that region. The tumor size, as long as it's confined to the kidney, should not be an issue. And also SABR is non-invasive. So overall, encouraging data continues to emerge regarding the use of SABR in the management of patients with non-metastatic kidney cancer right now for patients who are not good surgical candidates or who do not want to go through surgery. So now we're going to shift to discussing the use of radiation in the setting of patients who have metastatic kidney cancer. So right now there are 11 trials that have been out in the literature, roughly about 350 patients. And what that data says is that the area that is treated with SABR, you can anticipate 80% plus chance that that site can be controlled with radiation. It's really important to indicate that that does not mean that another site pops up. So it's the specific site where radiation is being treated where the local control is at. So, in the setting of metastatic cancer, as we continue to learn more about our patients, there is a newer concept that has continued to evolve. And we know that we cannot put all patients who have metastatic kidney cancer into the same bucket. And so there's information out there that says that patients that have a low burden of metastatic disease, which is usually less than 5 total sites, not including the brain, then that term is called oligometastatic disease, where oligo means few. And so there have been 2 prospective trials that have looked at patients with oligo or few sites of metastatic disease. One is a phase 2 trial, 23 patients. All of these patients have not received any systemic therapy. They had less than 3 sites of disease. SABR was delivered to all of those sites, and the treatment was either 1, 3, or 5 total treatments. At 1 year, they found that 91% of patients did not need to go on systemic therapy yet. The second trial is in 30 patients. All of these patients had oligometastatic disease. In this one, it was less than 5 sites of disease. Radiation was delivered. In this one, 30% of the patients had prior systemic therapy, and 50% of those patients were what we would call in a favorable risk group. And what this study found is that 1 year, 82% of those patients still did not need to go on systemic therapy. So what about if we think about SABR with the use of some of these more novel agents out there like immunotherapy? And can delivering radiation to a site help the patient's immune system work better with that drug? So there's a concept out there that if you deliver SABR to some of the metastatic sites, but not all of them, then there can potentially be this cross reaction between tumor sites, and therefore your immune system combined with the immunotherapy may help reduce the other sites. And this is called the abscopal effect. Now there's been various trials that have started to evaluate this. So when you look at single agent immunotherapy combined with SABR, the response rates are really not that great. When you go to double agent immunotherapy combined with SABR, we see that that response rate actually gets a little bit higher, up in the 50 percentile. So what this says from this data is it's safe to deliver SABR and immunotherapy medications together, but we need to do more research, more work to understand the best way to optimize this. And I think a good way of thinking about this is the Goldilocks principle. You have to have the right tumor biology, you have to have the right immune response in the patient, and you have to have the right radiation dose to that tumor for everything to just fit just right, okay? And currently we don't know the just right process yet. So what about if you are on systemic therapy and your cancer is progressing on that drug? Where does SABR fit into that? So there's one prospective trial on this right now. It's in 20 patients. These patients have gone through multiple lines of therapy, whether it be a TKI or immunotherapy or the combination of those therapies. They had no more than 3 sites of disease that were progressing, and SABR was delivered to all of those sites. And what was found in this is that 70% of patients were able to delay going on the next line of systemic therapy at least 6 months. Very encouraging information. So, in summary, SABR to metastatic sites, lung, bone, lymph nodes, may provide more than an 80% chance to control the disease at that site. But sometimes patients can develop cancers in other sites, and so that's an important thing to consider. Remember, SABR is like a virtual surgery at that area. In upfront oligometastatic disease, less than 5 sites of cancer spread, SABR may be able to delay systemic therapy for up to 1 year in about 90% of patients that are well selected. In patients who have progressive disease while they're already on systemic therapy, SABR may provide them the opportunity to delay going on the next line of therapy by about 1 year. More research is needed to optimize how we combine SABR with systemic therapies, with surgery, to improve our patient outcomes as we continue to move forward as this fight against kidney cancer.